Three.
Good afternoon. Greetings from IAPCON 2022. We are starting with our first session, which would be about sustaining palliative care workforce. I would like to introduce our chairperson for the session, Ms. Sangamitra Iyengar. She is a psychiatric social worker from NIMHANS. Ma'am has been working in the development of this sector associated with HIV, and she has been associated with Samraksha for last few years. And the second chairperson for the session is Mr. K.M. Nuruddin. Sir has been involved with Alpha Charitable Trust, and he is also the chairman of Alpha Palliative Care, one of the largest palliative home care provider in Kerala since 2005. I would like the chairpersons to take the session forward.
Yes. I think Dr. Moira Lang really doesn't need any introduction. We've known her for decades. But just for people who are joining for the first time, she's a global palliative care specialist and currently with Makerere, I hope I got the pronunciation right, in University in Kampala. She's also with the Global Health Academy in Edinburgh with Pal Chase and with Carriers International Palliative Care. She's had more than 30 years of experience. And she's worked in 4 continents. Her main interests are global health, transformational learning, fragile settings, and health systems integration. And she has many major achievements, which we can see. She has a very interesting topic, compassion and humanity, as part of sustaining the health force and looking at self-care. So over to you, Dr. Moira.
Thank you so much. It's absolutely wonderful to be with you. Only thing better would be there in person in Jaipur. The tech team have very kindly recorded in advance, so I'm going to allow them to start the recorded talk just in case internet from Uganda is not so good, and then I'll be able to take a couple of questions. So if the tech team are ready, please go ahead. And while they're just getting sorted, thank you to the organisers for everything they've done to make this happen. And it's brilliant that they're starting the whole of the conference in Hall B looking at sustaining the workforce. That sends a very strong message, and I'm delighted to see that. I'm delighted to be able to address this topic today because I think looking after ourselves, particularly in the era of COVID-19, is so important. I've called this self-care, compassion, and humanity because we talk about humanity and compassion in relation to our patients. But I wonder how often we think about compassion and humanity in relation to ourselves, in relation to how we take care of ourselves in order that we can then also take care of others. I'm joining you from Uganda, but I've had the privilege of working in India for 20 years and also being part of the council. I'm working here with Makerere University, but I also work with Edinburgh University and with Islamic University of Gaza and with the palliative care in humanitarian settings. I'm also medical director of Cardis. This is a phrase that we're seeing at the moment. I think it's quite an exciting phrase. Awareness, so understanding the problem or being aware of the problem. Empathy, a response, an emotional, a deep internal response to the problem, plus action, so we do something about it, is compassion. Now we see this phrase and we think about it in terms of how we design our programs. This is being developed within the global health community. We think about it in terms of how we might practice our palliative care. But I want us just to turn. Okay, I think we've discovered that actually the internet is even worse that way. Let us try the old-fashioned style and see how we get on. And I'll move to the slide. Okay, so what I was trying to talk about was this, this equation, if you like, which is called awareness plus empathy plus action equals compassion. This is something the global health community are talking about in relation to how we offer healthcare. But I want us to think of how we use this equation and turn it to ourselves. How can we be aware of the pressures that we're under and of the dangers maybe of us becoming either burnt out or exhausted or even developing a mental health problem? How can we show ourselves and each other empathy? About tenderness and kindness. This quote from a Gaza student, palliative from some background, compassion, satisfaction, this idea that what we do makes a difference, that what we do gives us meaning. That is actually very, very important. And in palliative care, I think we have that to a large degree. It's one of the privilege of working in palliative care. But do we give ourselves the same compassion that we give to our patients, particularly at times like this when we're pretty exhausted? We know this quote, don't we? We know it so well. The founder of the hospice movement talking about how much individuals matter. And I just want to ask that question of you. Do you realize that you're one of those people that matter, that really matter? And have we turned those amazing concepts of humanity and compassion to ourselves? And have we thought about how, you maybe put your name inside there. You matter because of who you are. You matter to the last moment of your life. Yeah, please think about that and think about how you are living, because of course we know that the more you are refilled, the more you will overflow with that to others. But if you're dry and empty, you're going to struggle. We're in a time of huge pressure on healthcare systems. These pictures will be familiar to many of you. A young Italian nurse, exhausted and sleeping across her desk. And of course, scenes from Delhi. It's a very painful time. I've been part of a group called Palliative Kerala that has taught over 2,000 people online in the era of COVID-19, and many people have shared their existential distress. And of course, we spend a lot of time talking about what is the meaning and the purpose and connectedness and hope for our patients. And so I ask you the same questions. Where do you find strength and hope in difficult times? What are the beliefs and values that anchor you? Are you part of either a faith-based or a community support system that gives you that connection that is actually a very important part of our spiritual health? Or are you feeling like this, a bit burnt at both ends? I was sharing this, I'm going to share a few images from this artist. He has written a book, and he's also become quite well known during COVID-19 in the UK for his very moving images. And this one I think is particularly helpful, looking at, it's a conversation between a horse and a fox and a boy. What's the bravest thing you've ever said? Asked the boy. Help, said the horse. We also know that this is something we should be providing in our workplace. This again is from the Palliative Kerala toolkit. You can see the link, including some excellent resources about managing COVID. But what are we doing? If you're a manager on this call, and I speak to myself, I say that if you have people that are working for you, how are we really making sure that they have a safe environment? We do have a tendency in healthcare to want to always go the extra mile. And while I salute that, and I'm part of that, let us also remember we can't go the extra mile if we run out of energy, if we run out of health, if we run out of hope. I'll take a moment to talk about these terms, compassion fatigue, that sense where we've almost run out of being able to show compassion because we're just too, there's just been too much for us to cope with. There may be vicarious trauma. We listen to other people's problems and challenges, and it's a privilege to do that, but we can start to live those out as well. We're not refueling, we're not regenerating, and it's hard to then care for the next person. And even we might be operating in a place where we don't write moral distress. I heard many people on that COVID-19 training saying that they felt undervalued, that they were going home to situations where the community were afraid of the doctors and perhaps persecuting even them. Hearing that in hospitals in India, don't we, about people attacking doctors, and and nurses, we're finding that painful. So there's all of these issues. And then there's the more insidious long-term burnout where we're just exhausted. We no longer enjoy our job and we feel quite powerless. In fact, a lack of power in your work environment, a lack of control really contributes to this. The last one is slower to onset and slower to improve. The first ones, if we can pick them up quickly, either change our work environment or change the way we interact with it, or make sure we are more refueled, so we are healthier in that environment, can help us. Some people have talked about compassion fatigue being the cost of the emotional support we give to others. And this is it's a complicated diagram, but it talks about all the different things that come into play before we get to that point. And it also helps us see the ways in which we may be able to make sure that we stay healthy and our colleagues stay healthy. This is powerful, isn't it? The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. I think we can identify with that, each one of us. Perhaps we've had the sense that we were walking on water. We were, caring for the next person and the next person and the next person, and yet actually we ourselves are struggling. This is not something to be ashamed of. It is a sign of the care that you have offered, and perhaps the care that you're offering to your family members, to people in unity. This giving and giving and giving until you feel tired and exhausted. But those very moments of hurt and wounding, whether it comes from our personal experience or our identification with our patients, are incredibly precious. A palliative care colleague years ago wrote a beautiful book called The Wounded Healer. So don't be afraid of those wounds. Don't even be afraid of the times where you do feel that you're exhausted, because in those times can be a deeper level of empathy with yourself and with others, as long as you get the help you need to heal and to refill, and then be able to care, perhaps with a deeper degree of empathy. So I ask you this question. If you have a piece of paper, this is not interactive just now, but we'll have time for questions perhaps later. What makes you less compassionate for a moment, and write down some of the things or think about them that makes you less compassionate? It may be the type of patient you're seeing, if we're honest about that. It may be the aggressive relative. It may be actually just the feeling that it's just all too much. Here's some of the things that people have said to me when we've been discussing this in other forums. This combination of some of the things I've mentioned, some of I haven't, lack of appreciation, this unrealistic expectations. I visit Gaza quite often, and I see this daily struggle, so that one more loss just seems too much. And I think COVID-19 pandemic has shown us that actually that can happen to all of us, faced with something like a pandemic, or just faced with the overwhelming sense that there's people who we'd love to care for, but we don't have the resources to do what we'd like to do. And on top of that, something is happening in our families. And then, of course, the flip side of that, what makes you more compassionate? And you'll answer this for yourselves, but all of these things at the beginning are true, but I also want you to think about the values, the feeling of worth, meaning and hope, which probably doesn't come just from your work. It comes from other aspects of who you are. And yet, when we're busy, we can neglect those other aspects of life. For me, this one is important: joy and laughter, spending time with children, spending time in environments where you're not for me, the doctor; for you, the healthcare worker, the counselor, you are a person and you're able to share love and compassion and joy and laughter. This might be watching a sunset, listening to beautiful music, dancing. It doesn't need to be something intense. It can be something, for me, it's walking on the beaches of Scotland, for example, which I love to do. So we're very well aware of the things that contribute to being exhausted, aren't we? Here's a list from a very useful a talk given by Prime, a global education organization, talking about some of these things that can happen. I love this picture, isn't it? Is your mind full or is it mindful? These two things are very different. I have to confess, mine is usually mindful, but I am very well aware, and I have people in my life that will challenge me. I've asked them to say if they think I'm actually not getting this balance right. But you can see many factors here. Some of them are inherent to our personalities. Some of them are part of our external environment. But remember, facing complexity, challenging ourselves, taking us, a little bit closer to the edge is not necessarily a bad thing. It may be a place where we grow, where we develop, where we understand more of ourselves. But we need to do that with care and with refilling and looking after our health. Nothing beats kindness, says the horse. It sits quietly beyond all things. I think that term kindness has become more important, hasn't it? Kindness to ourselves, kindness to one another, kindness in the middle of overwhelming difficulty. And I think in a sense, it's a soft term, a soft value. But I'm realizing more and more how important this is, that those moments, those quiet moments of kindness. So I want you to just think about how you know that you're not doing okay. How you know in the physical domain, the emotional domain, the social domain, the spiritual domain. Write some of these things down. If I was with you in a room, we would interact and talk about it. But just think about it. I'll give you some suggestions. Our hearts race. We can't sleep. We maybe eat too much. We don't eat enough. Maybe we drink too much. Maybe we eat too much chocolate. Maybe we exercise too much. Maybe we don't exercise enough. Maybe we've got stomach pains or migraines. Think of the sorts of ways you know that you're not doing well. Perhaps it moves into free-floating anxiety and mood changes. Emotionally, we're angry, we're irritable, we're sad, we're tired. So many things can be wrapped up in that emotional. And of course, I love this diagram because it shows the intersection, the intersection. We become isolated or we party too hard. We find we don't interact with those closest to us as much. We're spending all our time in our work-related things, or we're hiding a bit when we go home. In the spiritual domain, it could be to do with our faith practices. It could be to do with no longer enjoying things that we used to enjoy, no longer finding that spiritual refreshment from the music we love or the art we enjoy. Or maybe it actually is about our faith and a sense that we've been abandoned. Very painful. And so I ask you the second question, how are you going to take care of yourself? Now, I want you to think very practically of all the things in these domains that can help. It might be your favorite meal when you come home in the evening, or your masala dosa. If I was in Kerala, I was talking to Chitra last night, and that's what she was going to have. It could be going for a long run or a walk on the hills or the beach. It could be a hug with the person that means most to you. It could be the smile of a child. It could be dancing in the rain, even when the monsoon comes, or just dancing anyway. It could be making sure you make time to write down something in each of those domains, 2 things ideally. And I'd like you, after this conference ends, to make sure you do them. Make sure you do them. Don't feel guilty about them. Don't see it. I hear people saying, I think I deserve this. Actually, your patients deserve it. Because if you're going to care for the next person, you need to be healthy. You need to be strong. And maybe get somebody else to help you with this. Tell them you're going to do this and ask them to hold you a little bit accountable. Many things stop us looking after ourselves. And I've listed some of them here. I think guilty is a strong one, isn't it? We almost feel we shouldn't be looking after ourselves because we should be caring for the next person in need. Sometimes we're just so busy we don't get round to it. But I would suggest that, in fact, the priorities need to change. We need to look at it more like this. We need to have, remember I talked at the beginning, that awareness, and the empathy towards ourselves needs to be important. And I hope you leave that today feeling that. And therefore we take action in order to show compassion to ourselves, in order to show compassion to others. And so I want to finish there. Thank you for even coping with the internet challenges. This was again a drawing done by that same artist. It was drawn during the time where India had that very devastating second wave. So I think I would want to say thank you to each one of you. I think you're here because you have compassion. You're here because you're involved in palliative care. You're here because you think that that person that you're caring for in front of you deserves that quality of life, deserves that value. And I would just say you also deserve that we thank you for every moment of care that you've given. We thank you even for the times where you've struggled to give that care, but you've still done it. And we ask you now, and I ask you now, please do also care for yourselves and take care of each other, that we can continue with some incredible purpose that we have in palliative care to seek to alleviate suffering. Thank you so much.
Thank you very much, Dr. Moira, for really giving a beautiful start to this conference. Because if we are not there, then who is the carer? So, and it's where we are today. We are bringing in, it's the merging of the East and the West, the mindfulness, the compassion from the East, and the different caring things which came from the West. And just to summarize, because I'm not going to take much time since we're already running, just to summarize, you made 3 critical points of being self-aware and self-aware of everything around us and self-aware of where we are, how we are feeling, what we're doing, what's happening to our bodies and our minds. And accepting if something is not working and responding to it and doing to ourselves what we want to do for others and not feel guilty about it. And the compassion that we have for others, which is the hallmark of palliative care, if we can turn a little bit of that to ourselves, because if we are not whole, if we are not healed, there's little that we can offer others. So thank you. And we can take the questions at the end of the panel discussion. So if people can put the questions into the chat box. Thank you.
Thank you.
We move on to the panel discussion. Sangamitra ma'am.
Yes. Are we going to get the tech team to display the CVs?
Sangamitra is part of the recording, so I think we can just go ahead.
Okay, Dr. Nandini Vala, I think you are next.
Yes. Thanks. So I'll be moderating this session, which is titled as Let's Talk Money. And
So welcome to this session of IAPCON 2022, Jaipur. We would be starting with an interesting session on Let's Talk About Money. I have with me the various stalwarts of palliative medicine from various parts of India, and they are one of the some people which we look up to when we are talking about palliative medicine in India. With me, first I would introduce the panelists of my session. The panelists are Dr. Raghavendra Ramajulu. Sir is lead consultant and head at Aster Group of Hospitals, Bangalore. He has a vast experience in palliative medicine and pain management. And next is Dr. Ambika Rajvanshi. Ma'am is Chief Executive Officer from CancerPort, New Delhi. She has been working with CancerPort since a very long time. Dr. Gayatri Palat, Professor, Department of Pain and Palliative Medicine, MNJ Institute of Oncology, Hyderabad. Ma'am is Consultant Board of Trustees in International Childhood Palliative Care Network, and she played a key role in establishing district-based palliative care program in the Department of Palliative Care at MNJO, Telangana. Dr. Naveen Salins, sir is coordinator Manipal Comprehensive Cancer Care Network, professor and head of Department of Palliative Supportive Care, Kasturba Medical College, honorary professor at School of Medicine, Cardiff, UK, and also associate editor, BMC Palliative Care, UK. And to moderate the session, we have Dr. Nandini Valar. Ma'am is professor in Department of Pain and Palliative Medicine, National Academy of Medical Sciences, Bangalore, Karnataka. And she is also a consultant at Palliative Care Division, National Cancer Grid, India. She has a vast experience of working in India, and she has her key area of interest are equity, nexus of care and education in palliative medicine and advocacy. So to take this session forward, I would invite Dr. Nandini Valar. Ma'am.
Thank you so much, Gaurav, for that kind introduction. And it is wonderful to be having fabulous panelists with us. And so for the audience, just to let you know that we want to discuss the funding aspects of running palliative care services and for reimbursement of the professionals through these specially selected panelists. And each of them represent specific sectors. Ambika represents the non-governmental organization sector. Dr. Naveen represents the academic institutions. Dr. Gayatri represents the government organization. She's working for the Regional Cancer Center. And Dr. Raghavendra represents the corporate sector. So we will try to hear, from their experience about how to go ahead regarding initiating and supporting services, as well as giving reasonable reimbursement to all the team members involved. So let me begin with you, Ambika. I see that on your website, you all are the leaders of home-based palliative care program, and it's the largest free home care services. And I noticed 150 care providers on your homepage, and you all are seeing 2,600 patients and families at a given time. And so, could you tell us more about how do you look into the services? How do you, from the funding perspective, if you could just let us know how you go about prioritizing, raising and allocating your funds. Ambika, over to you.
Thank you, Nandini. Well, CancerPort was established by Mrs. Ramala Gupta, cancer survivor, back in 1996. And this is our 25th year caring for people with cancer. So we run free palliative care and supportive care programs directly in 4 northern states of India, which is Delhi, Punjab, Haryana, and UP, through our 13 district centers. And the programs are designed basically to help cancer patients and families throughout their cancer journey, right from diagnosis to end and even beyond. And we've also replicated our model in other parts of the country in partnership with various state governments, trusts, and foundations. As you rightly mentioned, home-based palliative care is our flagship program, and we have 28 multidisciplinary teams across these 4 states, along with 3 outpatient pain and palliative care clinics that provide direct palliative care services. And in addition, there are supportive care programs like the daycare, peer support, helpline, third-party resource facilitation, and community outreach. All these people look after about cumulative about 5,000 patients and their families at any given point in time. This year, we have a huge budget of 9 crore, out of which 85% is allocated to programs. 5 is for resource mobilization teams who actually get the money and the resources to run these programs. And 10% is covered under admin overheads.
Thank you for that. So when you say 85% is for programs, like what, could you just elaborate a little on that?
Yeah, this is nearly about 8 crore that is spent on various resources, which is salaries, the vehicles, medicine and equipment, the centers that we run out these programs out of, and the training and education that is involved in keeping our teams updated with the latest knowledge.
Okay, thank you. And for cost efficiency purposes, are there, do you have certain policies when it comes to, say, initiating a new home care service?
Yes, absolutely. Well, there is a process by which we start a new service, which is at least 30 to 35 new patients in a particular team consistently for over 3 months. And since we've been working for the last 25 years, we are pretty aware of the trends that will allow a particular team to grow over a period of time. And the resources for this particular team are generated 6 months ahead. It really takes that much time to get this money. Each team for us, runs for about 20 lakh a year. So if we need to get it through a corporate, a trust, or a foundation, the work has to start 6 months ahead.
See, that's so important for us to know, because, I think this is what, is the experience sharing that matters, and your managing of your back office statistics. So we can learn a lot from you, how much we need to prepare even to initiate one home care service. And that average figure that you gave is so vital for a new person who is wanting to start home services. Now, thank you, Ambika. We'll come back to you later. So now, shall I move on to MNJ, Dr. Gayatri? We are so obliged, and we are honored to have you here. You have been a major national level, international level faculty and trendsetter in India. So I also looked into your website of MNJ Institute, and I see it has been there since 1955. And the most important attractive part of the website was that palliative care is very prominently seen on its homepage. And so I'm sure that is, reflective of the importance and significance that the Institute is giving to you. Could you just tell us as to how do you handle your priorities and services, and, from where do funds reach you, etc.? Over to you.
Thank you very much, Nandini. Yes, I think the government of Telangana has, it's very unusual, actually, I would say rather, that they give so much of importance to palliative care in the state. So when I talk about palliative care from the government point of view, we have two kinds of setup. One is what is happening in MNJ Cancer Hospital as a tertiary hospital, tertiary referral hospital for cancer, and having a full-fledged department of palliative medicine. We have all the faculty position, like from a professor to assistant professor, and staff position like nurses, social workers, physiotherapists. We have 10 full-time nurses working in palliative care, like that. So, and it is by the government, like it's entirely funded by the government. So it's a position created for that purpose. And it's a very busy program. And then the other aspect of government-run program is what is happening in the districts. In all the districts, 33 districts we have, and government has ensure that every district has a one palliative care unit, which is by the government, with a proper position for doctors, nurses, and other healthcare workers involved, including physiotherapists. And these positions are also funded by the government. Now, the district-based palliative care program is funded through NHM, but by the government. And these are all positions created. So when you talk about money and like how much government, normally they are very reluctant to support human resource, and because palliative care is generally very human resource heavy program, and government has done remarkably well in these areas. Yes. Yeah.
So to just follow up and understand more, how much of, like, I understand that the full-time positions in the hospital are coming from state government funds, and the district programs are getting from the NHM funds, which are dispersed from the center, but also supported by the state NHM. Is that so, or is it a different style in Telangana?
So if you just look at the district program, it is a national health mission program, and the money comes from National Program for Palliative Care. Every year there's a flexipool, and they apply for funding through the flexipool, and it's again government's discretion. They need not ask for money for palliative care. They can divert that money to other programs in their entire big PIP, which they roll out every year. But here they decided to give a big chunk to palliative care, and they apply for that, and it's a 60-40. So 60% comes from the central government and 40% from the state government. Otherwise, central government will not support it if the state government is not putting in their own money. So that's how it is: 60-40, 60% coming from central government.
Okay, that's great to know. And I will definitely ask more questions on that for those who want to do it at their own states. Let me, get more information on similar area from Dr. Naveen Salins. He is representing the Academic Department of Excellence at Kasturba Medical College. And I can see that, you have first in several areas of achievement at national level. And there is a lot of research and non-research grants, which are seen on your website. And you are serving not only oncology, but you are serving so many subspecialties, ICU, pediatric, renal supportive care. So, Naveen, would you be able to let the audience understand how you have achieved the funding required for, a service like palliative care, which is still not fully understood? So over to you.
Thank you, Dr. Nandini, for this question, and thank you for inviting me for this panel. Firstly, what we need to understand is what is the motivation behind for an university or a teaching college to start a department like palliative medicine. From an university perspective, if we look at, they always look at adding specialties. It could be subspecialties or specialties, and palliative medicine is a recognized specialty. And especially leading institutes always would like to see more specialties added to their college or university. It demonstrates the breadth of the training that exists. Two, it influences their ranking. Three, it improves the overall research output and the visibility. So that's the motivation behind it. Now, from the hospital perspective, why they want to invest in a college in palliative medicine is they would not just look at the direct patient benefit. There's a lot of indirect benefit here, especially in the teaching college, because they're undergraduate, postgraduate teaching, and also the value addition that we could add. If I could give one example of what we have done with an integration of palliative care services with the ICU, in exactly 1 year before we had started what is called as a critical care review board, where any patients who stay for more than 7 days in the ICU needs to be discussed in the critical care review board, and the review board has palliative care person. And when we did an analysis, what it showed was that the average length of stay decreased from 15.4 days to 9.2 days because of the critical care review board and palliative care intervention. This was a huge economic benefit actually for the hospital. So this may not be directly tangible benefit, but indirectly there are so many ways. So in a university teaching hospital, there are several motivations, and it's when we need to tap on to those right motivations and appeal to those right motivations, which is very important. And the funding, universities never look at short-term gains. Like suppose you have a hospital, they may look at, okay, what is I'm going to gain in 1 month, 3 months, 6 months, or 12 months. Universities do not invest like that. They look at what is it 5 years, what is it 10 years down the line. So they're all long-term prospects, and definitely palliative care has long-term prospects.
That's completely a different point of view that you mentioned, and I'm sure that the vision of the institution matters a lot in what based on what you mentioned. So would you like, because now I'm going to also would like to know how palliative care aligns with the vision of the academic institute?
Yeah. So previously, if you take 10 years 15 years behind, most of them were more focused in filling the seats and just as in from a college perspective and collecting the fees. Now things have changed. Students are very smart. And the first thing the students look at is what is the national ranking of the college? What are the breadth of the training program that exists? And now the institutes that gets the highest ranking or the most seats filled are the institutes that has the breadth of specialties that exist. That's very, very important. Two, there is a lot of work that goes on cross specialties. Now we have integrated very well with the nephrology team, ICU team, and pediatrics. These are our three core areas apart from oncology. And this is paying us a huge dividends in terms of lot of new research areas, niche area research that is going to come out of that. And this has helped us to get a lot of grants. We've got several grants now coming, and there are several grants coming in the pipeline. So a lot of the support staff automatically will get employed through those grants. It's like the social workers or a lot of nurses that we are having are coming through the grants. And actually, this leads to more further grants. So whenever you're applying to a grant agency, they'll always look at your track records. So it's like what is called as a snowball phenomenon. So I think our focus should be on our specialist skills and how we integrate and work with the other specialties. And I think that's the key for survival for the future of palliative care in India. Rather than working in a silos, this is my perspective.
That's, I think, yes, it's very relevant and meaningful, and that makes sense as to how you have been able to achieve so much in an institution, and with alignment of their vision as well as the visibility in the national international scene. Great. Coming to you, Raghavendra, palliative care has really made its mark even in the corporate sector over the last, I think, 10 years or so, but it's the most recent entry. Having said that, you have been very successful in activating it at your institution, which is definitely a corporate sector. Would you be able to tell us more about how it, how did you approach this?
So I would thank IAPCON for inviting me for this panel, and I thank you for those the introduction, Gaurav. And ma'am, I think I'm following your steps and Dr. Naveen's steps to actually start from HCGS. It's been about 11 years now. I think you were there in the corporate sector. Now, in terms of actually the visionary is what is most important, as Dr. Naveen sir has actually mentioned all of it. So what is actually for the institute, coming to the present institute I'm working at, Aster is actually having 27 centers, 27 hospitals. And as a group, it's not able to actually provide pain and palliation to the extent which they want. That's the same lines which our CEO has mentioned to me when I did go and meet him for the first time. So in terms of actually why is it required, coming back to that, so it's more of service provision, and the hospital wanted that service kind provision, and people would look in for what is the service best for their kith and kin. So palliation was something which is not there. And if you look at any of the hospitals in Bangalore or any of the other centers in Aster to the established level they want. Now, their idea of palliation was to actually provide extended care services at home. Now, that is something which they want to initiate, and we are on the thought of actually providing. So it's been 1 year in Aster. So we are able to establish OPD, IPD services, as well as in collaboration with certain other third parties, we are able to provide home care services. Now, we don't want to do home care services. We wanted to actually do extended care services. Now, most of the patients feel saying that they are actually abandoned once the treatment is done. So that is something which we want to actually prevent. Or there are other aspects which Dr. Naveen sir did mention very well. Now, there are certain aspects wherein the bill starts bringing up for them for unwanted ICU stays, hospital stay and things, wherein the patients actually have given a lot of feedback saying that they don't feel saying that they're looked for or cared for. Okay, let's take for example, if a patient is actually provided with any form of end stage organ failure is there and they've gone for a transplant, that doesn't work. Or the patient is not there for fit for an organ transplant, or other comorbidities are there. So we need some form of service which could look after the catering the needs of all these group of patients. To actually add to the background, Aster does not only serve only for oncology patients. It's a multi-speciality hospital which has got all forms of specialty, starting from pediatric to geriatric, and all the other specialities could be like niche like pediatric rheumatology, pediatric neurology and things like that. So therefore, you get the end-to-end cover. It doesn't allow only for pediatrics. It doesn't allow only for geriatrics. So it's the entire gamut, not only oncology, and we look in for all forms of supportive care in terms of whenever there is an organ failure. Now, the visionary is there. They wanted the service, and there were other people who are coming from CGHS and ECHS also. Now, beds are locked in the ICU and other places just because they don't have to do anything. So at one place, one corner, you're taking saying that somebody is actually shelling out their money. On the other end, they would actually, even though they're told 84-year-old, multiple issues, concerns, still they want ICU for no reason. So somebody need to talk to them, understand saying that they're not going to get abandoned. And extended care or services provision at home, ECHS, CGHS does not pay for them at all. Where should they go? So I'm actually meeting a gamut of groups wherein the service provision should not. So the underlying statement is service provision is something which should continue. That's what Aster basically wants. So that's where we actually have got into. And it's been a pleasant journey for the last 1 year. And we're looking ahead, not just to actually have a part played. I think we are looking ahead to play something called as Aster Holistic Collaborative Care, wherein we are trying to integrate the entire services which we could actually offer to them, not only at the hospital, we actually extended care at home also.
Great. So what I'm hearing, maybe in a very simplifying all the inputs that you gave, corporate sector, the patient experience, and the feedback, the quality of care is very important, and that is a driver. In academic institutions, the standard of care as well as standard of education, which goes along with it, along with research, is a huge impetus to palliative care services development. And I think in government, of course, the policies and the access to public funds and public health is probably, has played a major factor. And in NGO, it is the passion to provide services irrespective of the equity to the access of care is driving the force. So I may have oversimplified, but I want to go to the one important question in each of your sectors. That is, Ambika, I see that there are all individual donors as well as corporate donors, because you all are donor-driven organization, and of course they are donating because of tax advantages. But I'm really curious to know as to there are so many worthy causes for donation. Why does a donor stick to donating to you, or begin to donate to Can Support and not anyone else? How do you inspire a new donor to support Can Support? And I also follow-up question I want to ask is also, are there any non-negotiable policies that you adhere to when it comes to funding?
Sure.
Yeah, please go ahead.
So Nandini, 25% of our funds come from individual donors. And over these years, we have found that these donors have been largely those who've been touched by cancer, because only then they understand what is the meaning of provision of palliative care, that good quality of life and even quality of death is important than longevity and survival. So Can Support provides these donors ways to find meaning in suffering, such as honoring a loved one taken by cancer, or find connectedness with others engaged in battle with cancer, or experience the joy of contributing to others while receiving tax exemptions as applicable. So while we provide care to the most underprivileged, there are a few who have the reason, will, and the means to give back to us. And they are the ones who become our friends. So fundraising from individuals at Can Support is more friend raising than anything else. And resource mobilization is about relationship management. We try and make our donors go from being strangers to someone falling in love with our cause. And when this happens, they make the cause their own, and the support multiplies. In fact, this is how I came to Can Support, because I fell in love with its work. For institutional donors, 70% of our grants and funds come from these institutions. So we make available to them opportunities to fulfill their board mandates if they are trusts and foundations, and their CSR obligations if they are corporates. We have studied and tried to understand the CSR regulations deeply and fulfill its requirements as best as possible. Companies now have to work under stringent CSR rules and regulations that are updated or practically on a daily basis. So when we comply to their expectations from us, we help them comply to theirs in turn to the government, their CSR obligations.
Great.
So it is a partnership that matters.
Yeah.
It is very important that we honor the memorandum of understanding, the agreement of partnership that we have to its last detail. Carefully deploying, all these receipts to the programs and not to anything that is outside the agreement, fulfilling the reporting requirements, and we utilize the budgets as outlined in the agreements, maintaining transparency and accountability in managing their funds. So this helps us to sustain our donors for years. Additionally, it is also very important to give the corporate donors their brand exposure.
Okay.
It makes business sense to them, but also brings credibility to our work that so and so big corporate is associated with us. It acts as a catalyst to interest other donors to support our work. However, brand exposure does not mean brand promotion. These are two distinct things. We need to be careful about that.
Thanks a lot, Ambika. So that was, we got an idea, but there is a lot of back office work that is required to maintain this kind of, support systems satisfied and ongoing. Great to know. Now coming to your work in Telangana, Gayatri. Suppose Gayatri Palat didn't exist, would it have happened? What I want to know is, why would a government be so motivated to make this happen? What all were these steps which allowed you to reach the level that you have reached in Telangana? Could you just grossly tell few of the major steps? Thank you.
Thank you, Nandini. I think a few things which really helped, which was very critical to make these things happen, was having a kind of consistent person pursuing it. It really helps. Yes, my presence was critical, but then I had this team. Like as Ambika said, like-minded people coming together and pushing for the cause was something very critical, and that really helped us. Like so that I wear two hats: the civil society hat and as well as the government hat. So the initial push by the civil society was very critical to make it happen. Other thing is that like most organizations who are starting new, I always feel that is donors and funders, if they give some initial seed grant and start a program to show that it works, it's very helpful. And that worked for us a lot. Initial, all newer aspects like pediatrics, starting pediatrics or starting adult program, we got some initial seed grants and we established those programs, did a good job, quality program we did, and we showcased that it works. And
So
government.
you mean to say a demonstration project kind of period, and then
Absolutely, that's how it worked. We did a demonstration project within the government system, showed that it is important, and we are right now today like indispensable. It's become like that. So that's how it works. So that showcasing and making a demonstration project that was another reason why it worked. Somewhere, even in the government sector, like how Ambika mentioned, having someone lost to cancer and experiencing that, dealing with death and dying, I always found someone at those level, bureaucrat or ministers level, having that experience. And I always got that, I was fortunate that I could get those people sitting in critical positions. And finally, I think when you talk their language, saying that how most of these people who are coming to hospitals are from the villages and they're dying there in pain and suffering, if they really understand that language, that public health issue, it's a public health issue. Because most these end stage conditions, when they go back and they're dying in agony and suffering, and they're in the villages. So having this, then the government asked us, how do we have this population-based approach to palliative care? That's the reason this whole thing came into being. So having speaking their language is very helpful to roll out this program. And we wanted this universal access to palliative care in the state. Yeah.
so I hear that same, although both the sectors are totally different, both Ambika and Gayatri talked about that whoever is supporting the whole services, we need to align with, their concept of what they stand for. And, this should help emphasize who they stand for. Great. So thank you for that input. And one small question follow up is the seed money you talked about. So that is not from the government, isn't it? So
Yes.
would you just for the people who would like to start in a new state, what is seed money?
So seed money is, I always say when you start a new program, start small and go slow. Start small. And still it makes a lot of impact. Like you just start with only the outpatient service, only for patients with cancer, only adult patients. Fine, do that. Start small, and you need a small amount of money to start that outpatient service. All you need is maybe one doctor and a couple of nurses, and that kind of investment, and finding a donor just to support that. And there are many donors out there. They're very kind to such kind of programs, support such initial grants. And when you start like that, and then and palliative care is a kind of such a work like the Naveen also explained. Once you start, it's like kind of it's no going back. It just grows bigger and bigger because the need is so much. So that seed grant is something just to take off as a project, just to kickstart the program. Yeah.
So that will be an individual initiative, and your advocacy skills and all come into play then. Yeah,
Absolutely.
great.
So sorry, I'm the important aspect is the constant advocacy with the government. Successive government. So many government changed in this entire duration, but they understood this one common language, the suffering, and having this lack of access in the most remote places. So that language really worked. And today, like we have morphine available even most remote districts, even most tribal districts, we have morphine available. Yeah.
Thank you, Gayatri. Naveen, you mentioned about how your department is, greatly supported by the management and administration. So how did they, the issue is generally, of course, once people come to know what is palliative care, they are supportive. But that understanding of what a palliative care department can do, and, that it is really, it is in alignment with what the management would like to do. For that, a dialogue needs to have a common point of reference. So how does anyone start wanting to start this in a new academic institution? Where do they begin, and how do they go ahead? How do they get to the point where you could discuss, okay, let us start this way, or even before they agree, you need to get into their room to converse about it, right?
So most of the time, generally we have a perspective, or a lot of people have a perspective, as either corporate hospitals or academic institutes, they have making money as one point agenda, which isn't true. I'm sure that is a very important aspect for any institute, sustenance and growth, but that is not the only one point agenda. For them, value addition actually plays an equivalent role as economic gain. And if you are able to demonstrate the goodwill generation, the value addition, and how it could probably have a social impact. Now, corporate houses are talking the language of social impact. Like, for example, we are now going ahead building a hospice. And there is a huge capital investment for the hospice. The capital investment is coming from the university as a social impact project. So now big universities, big corporate houses want to do social impact project, and palliative care is one such important social impact project. So you are able to demonstrate not just excellence in education and research, but also visibility for the university in terms of social impact. Because now, as I mentioned earlier also about ranking or visibility, social impact is one aspect that improves that. So I think that language, what you speak, is very important to take this forward.
Okay. So again, I see, a very aligned background from the other sectors also, that we all need to be very well versed with what the institution stands for and go along with that. And palliative care is a very visible, care system where, the intentions are so easily appreciated and understood. Okay, Raghavendra, what do you feel, allowed you to, reach a stage where you are in right now with the corporate sector?
So the most important thing I feel is after you've actually walked out of the administration room, the most important thing is having the right kind of approach to actually talk to your colleagues. And they would only respect if you're actually practicing evidence-based palliative medicine. And I'm thankful and grateful to Naveen sir, who is here, who actually built that evidence base in me. And I just want to recollect those days when we were doing rounds. I was in anesthesia and he was in the pain and palliative care department, and he did handhold me and teach me. I think those were the first strong steps. Without actually having good education about pain and palliation in terms of evidence-based work, I don't think so you will not be able to get along with your colleagues at all. They will never respect you. So unless and until you're able to actually change that, bring about the change, and you're able to actually make them understand, saying that there is a role for us and this is something beyond what they are actually doing, then only they will accept it. And unless and until your acceptance is not there for the next 3 months or 6 months, even the administration will look for it. And if you're able to bring that change within the entire group of doctors who are there on their panel, then they're going to accept. If the administration finds out saying that pain and palliation is something which they also envision as just handholding, talking something, or it's actually a part-time job, then you are not going to be accepted. The administration will come back and tell you saying that this is not the right approach, and I don't think so we would be able to continue and sustain. So I would actually give full marks to whatever my teacher and throttle on reading, learning, get your basics properly, make things which is going to actually bring an impact in a patient whom they have referred. the first 5 or 10 patients is what all our colleagues are going to look into. And if you're going to bring about a change, then they're going to accept it. So once you've accepted through all the doctors, the feedback is going to go directly to the administration saying that this is what has been made a big difference for them in their practice. And the patient is coming back happy to them saying that we have not been lost, we have not been abandoned. You are important as well as your team is important. So that is what is going to actually make life much, much more better. So first point, evidence-based palliative medicine, camaraderie within your team members itself, then actually talking to all people, understanding, saying that pain medicine is just not just hand-holding, it's beyond. So creating awareness, education is something which we will have to create at various levels. At various levels, it could be in a lead consultant at a different level, or it could be a nurse who's actually there, because nurses do get very, very scared in a corporate hospital to see a dying patient in the ward. They would rather feel very happy that they're actually shifted to the ICU, and that's where they actually see the end. Or the patient's attenders are demanding and asking multiple questions. So it's actually a lot of people need to be spoken to and actually told what specifically they are actually there, and this is something which is acceptable. So I think that's what I would actually see.
Okay, so we need to be confident and capable enough to stand tall amongst our colleagues and be commended, and be able to rationally justify the decisions and the care plan that you make for the patients. Yeah, that is a very important point that you brought up. So the money follows not the lucky, but the most capable doctor, palliative care doctor. Great. So I think these are all excellent points. And the last few minutes, I would like to, I want to hear from each of you a message that you would like to give to the young doctor who's raring to, go, and he may have decided to join any of these 4 sectors. And I would like to, ask you to based on all the experiences that you all have had, to give a few words of advice. So if 2 minutes, if each of you can speak on that topic, assuming it's the young junior consultant who's standing in front of you, it will be really useful to this audience. Go ahead, Ambika, you may start.
Okay, I think probably 4 messages, very short ones. So first is don't be overwhelmed by how much others have achieved in this field, but take inspiration. We've all started with 1 person in our NGO, with 1 patient and 1 rupee in our pocket. So growing slowly and steadily based on the requirements of our patients. When we need to eat an elephant, we have to take 1 bite at a time. Second is that if we have a good cake, it will sell. So focusing on improving the quality of our work, let the work speak for itself. We'll get more patients and we'll get more donations if our service is valued. And our beneficiaries are our best spokespersons, so no one can market our product better than them. Third is don't underestimate in-kind donations in materials and time as volunteers. They especially reduce our overhead costs. And I think the 4th and final one would be focus on servicing your donors as much as we have our focus on improving the quality of our work. We make ourselves so valuable to them that they cannot strike us out of their support list. And there's enough money in this world for all of us. All we need to do is ask.
Thank you, Ambika. And that is coming from the CEO of the largest home care network in India. So learn from her. Thank you so much, Ambika. I would request Gayatri for her message to the young palliative care consultant.
Thank you. So I think Ambika says it all, but still I just want to add a couple of points here. One, palliative care, I think, is the future of medicine in all aspects, I think. And there is going to be huge demand in private sector, especially in government. I think there are going to be departments created and there'll be proper faculty demand So we have to be ready for that, not just for doctors, even for nurses. I think there'll be huge demand. Like the number of nurse position I have created in the state for just for palliative medicine, I think it's a huge demand, and we should be all, and the social workers, pharmacists. So if we are not ready now, I think we'll be losing, we'll be behind, not meeting the demand. So there's a huge demand as a future. The second thing is that I feel really a little disheartened, I can say, because we have not really used the opportunity. We have the support from the government today. The central government is saying, please use the grant, use the money which we want to give to states, and it's there to be used. And still we have not really, most states are not using it effectively. And those who want to figure out how to use, how to develop palliative care in the government system within the state, they can always approach us, and we can guide them as to how to apply for those grants and make use of those opportunities to have this population-based access to palliative care in their respective states. Thank you.
Thank you, Gayatri. And all of you, please use this invitation and take help from her. Naveen, please requesting you to give your message to the young doctor.
There is a lot of disillusionment right now. There is a lot of disillusionment right now among the younger doctors who are doing MD or who might be doing DNB or MD palliative medicine, because they are competing, and do not want to use the word competing, but they are along with many other doctors who are practicing palliative care. But I feel that this disillusionment will slowly dissipate as people will start recognizing more and more specialist palliative care training. And I think if people practice palliative medicine with this specialist focus, I think over a period of next decade, I'm not in years, but a decade, I think we would be firmly established like any other clinical specialty with very good both growth prospects, economic prospects, and also work satisfaction prospects. I think all these three things will come in.
Thank you. That is very encouraging to the young doctor. Raghavendra, for a person wanting to start work in corporate sector, do you have a word of advice?
It's simple, ma'am. If Raghavendra can achieve, anybody can achieve. There is no thought to it, second thought to it at all. I think it's just about understanding what is required at each level, and don't actually take everything at one place. Break it up into smaller aspects and go back to learning. I think you're a young doctor. You should learn well. Don't think saying that you have to restrict your learning to a very small thing. You should actually, the horizon should be your learning point, and do all of it. And once you have learned which patient you're going to apply that, nobody would be able to tell. So it could be, don't think saying that palliation is only for the poor or palliation is only for certain aspect. So there are a group of patients and people who would come. So corporate is also a sector wherein you'll have patients. Affordability is going to be there. There are non-affordable patients also coming to it. So you will have a strata over there also. So please learn the entire gamut. The next thing is, whenever you look at healthcare services, I remember the point saying that most of the healthcare services are only for acute settings is what I've actually learned from Dr. Naveen sir. And now it's more of chronic care, which might require in the future, and going extended care, where we are actually following the footsteps of the West. I think that's where we are lacking, and we see a lot bright future for that. And none of the corporates are going to miss that opportunity. So everybody would like to do that. It's not only from service provision, it's not only from other aspects. As Naveen sir rightly mentioned, it is important for them, not just value addition also. They would like to look into their monetary gains, and monetary gains are going to be there. So it's going to be a justified monetary gain. Nobody in this world is actually saying that please provide a service for my kith and kin, please don't charge. They're ready to actually be there to actually be provided service, and they are ready to actually pay for that also. I'm not talking about every aspect of the society. I'm talking about there are aspects of society who would be. So in terms of that, future is bright. I'm sure you would be able to actually do whatever it is. but small steps, small thoughts, I think that's something which is going to cover the entire whole holistic way of actually handling it.
Thank you, Raghavendra. I'm reminded of the reasonably popular movie where Amir Khan says, "Kabil bano, kabiliyat khud ba khud aa jayegi." So I think with these discussions, we'll open our panel for question answers, and I request the audience to use the opportunity of this Star Wall panelists and ask your questions. Thank you, everyone, and we'll wait for the questions to come up.
We hope we get the questions for both parts of this session. The first part on compassion and humanity. This has been an extremely important session because, especially because of COVID-19, it's got really highlighted in many ways what would have happened over a period of time in certain, maybe in palliative care or in certain parts of care. COVID-19 brought it to a head. We saw what was compassion fatigue and burnout taking a long time. Suddenly, there was such an overwhelming need that it really impacted a lot of carers and a lot of palliative care carers. So this session has really looked at utilizing internal as well as external. How do you mobilize your internal resources and external resources to sustain the workforce? And we have the first question to Dr. Lang. Home-based palliative care in and around our city. Oh, it's a comment. Your suggestion is appropriate. First step where no concept or facilities. How do you, in an alien region, how do you initiate palliation, especially for funds? I think this is to the panelists.
Yes, Dr. Sangeeta, I think I request, this must be like something like a community. So I would request Ambika to start responding, because that may be more from her perspective.
I think when we started palliative care in Delhi, it was in a very nascent state. So it was still an alien environment where even the cancer, the C word was not spoken. And whatever I've heard from Mrs. Nirmala, it was all about sharing her own story as to what is the meaning of quality of life. How can we make a very challenging journey more manageable, meaningful and memorable for everyone concerned, is the message that she started giving around. And this was the message that actually resonated with many families who had undergone this experience. And these people were the ones to first not only receive the care that palliative care could offer, but also turn them into the first funders to make it more sustainable. I think messages, as we've seen in the panel discussion earlier, the correct messages where you align that person's or that institution's goal with the goals of palliative care is most important.
Yeah, and that's a very useful. Any other panelists would like to add from your perspective? Because an alien environment means somewhere where there is not yet, any amount of palliative care. So, Dr. Naveen, suppose there's an academic institute where the administration and the professionals are, not really aware. It's quite rare now, but still that question is there. So how would you begin?
So, as I mentioned during the panel discussion, the questions directed at me is always you have to convince them is what is the prospect of investment with respect to, it's mainly the human resources to start with. When we are talking in palliative care, there's a very less capital or capex investment. So it is the human resources. and what is the long-term prospect. I feel that when they come to know about the long-term prospect, most of them want to try out. It's like another specialty like physical medicine, rehab, or hiring an endocrinologist. Some of them may be more familiar, some of them are less familiar. But majority of the institutions would like to try out and see where this will lead. And that the expense that is involved in trying out is actually very small compared to the budget an institute has. And if it works, so when it started in my place, it was started with one person, one consultant to 4, which led on to a postgraduate program. So it didn't happen 4 coming at one point of time. The value of one was acknowledged. The usefulness of one was acknowledged. The 2 was acknowledged, and how there was a need for an extra. Maybe down the line we might have more than this. So it's how we demonstrate our effectiveness over a period of time. I think that's where funds, as Dr. Ambika had said, there are enough funds in India. We always think that there are lack of funds. There are enough funds. We have to actually seek and utilize it. That's what I think.
Actually, I'm sorry, there were 2 questions. The first question on Siliguri is actually asking Dr. Lang on her suggestion on palliative care around the city. So, Moira, would you like to take that?
I love it when questions aren't necessarily on the topic, but they are from the heart. So I just want to say to that colleague, please don't give up. Please connect with people in your region, because I think we can start small. I'm hearing from my academic colleagues some great stories, and it also really blesses my heart because 30 years of my career have been in integrating palliative care as an internal medicine physician. But, taking one step is still okay. So I've had a look on the Pallium India website. There is some links for Namchi and Gangtok. You will find also in the IAP website. So wherever you are, whether it's a home care program, whether it's linked with a hospital, please do find out what's available. If you've not had training, IAPC training courses are there. If you've had training, link up with people in the region and people in IAPC and Pallium India that can help you. And we wish you well. That's what I wanted to say to our colleagues there in Siliguri, up in Darjeeling. Mm-hmm.
Dr. Murali, may I ask a question linking the panel discussion with your talk? We have been talking about resources for palliative care in terms of money, and you have been speaking of resources to avoid compassion fatigue or burnout from within individuals. What can organizations and institutions do to prevent compassion fatigue and burnout?
Thank you for that question. I actually thought that panel discussion was great. And I also liked the way you were talking about establishing positions, getting things into salary programs. All over the world where I've worked, pioneers, and I know I'm part of that, we are pushed ahead to develop services. That's great. But if we haven't also linked that with formal deployment, and that I mean sometimes is working with the Ministry of Health programs for that, or as Gayatri has told us, there is a deployment there, and we need to get behind that and make sure we fill in those positions. So thank you for pushing the fact that we need to have these as paid positions, and we need to have it as a career plan, because that is also part of self-care, to be honest. If you have no sense of reward, both morally but also financially, it's very difficult to continue. The second thing is, in all of your programs, I think I do see staff support, but can that be a properly funded component? We look at our psychiatry colleagues, they have formal supervision, don't they? And I've been told many times by colleagues, and myself, I had some formal supervision some years ago, and it was a very helpful process, even though I'd been a consultant for 10 years. So I would actually challenge us as palliative care, as a professional growing group, to look and see what systems, formal and informal, we put in place for our staff care, to make sure that, Raghavendra, all that you have achieved so far, you're still achieving in 20 years' time, because you've had that support system to get behind you. So please make it a formal part. Please value it. Please don't model unrealistic working, which then your juniors feel they have to follow. And please do keep looking at how we can value every member of the team, the volunteer, the counsellor, get them involved in conferences, in research, in presenting, in academics, as well as obviously in the core of palliative care. Just some suggestions.
Thank you very much. And I think we are being reminded that the time is over, unless there is a very pressing question.
Yes, ma'am. If you allow,
Yes.
there is a question that if the different different speakers from different associations, if a new person would be joining any of the institutions, so would he be worried about the economic security under the various sectors? I would like anyone, everyone can pitch in. I mean, from a perspective of an NGO or a university hospital or a corporate hospital.
Is it okay if I start?
Sure.
All right. So, the remuneration for doctors or nurses when they join us may not be at par with what is paid in the government or in corporate hospitals for sure. But according to our analysis, according to our market research, it is certainly at par with what other doctors are paid in the NGO sector. So I don't think there should be any concern about the economy. And any person who would want to know would have their homework done as to what other NGOs are paying and what a palliative care NGO can pay. But having said that, I would also say that palliative care is not everyone's cup of tea. We've had people who wanted to join our work, but after one home visit, they say that it is excellent work, but this is not for me. So it is, I think, in an NGO, with or without the economics involved, it is more of a calling rather than a career. Because career, well, it pays, you're paid for the career, but you're made for the calling. And I think most of the doctors or the nurses who join us, they probably start with an economic thing, but over a period of time with their own value-based learning and self-reflection, monetary gain is only one motivation for their involvement with palliative care.
So, if there are no other pressing, burning questions, I think we need to conclude this session. As yes. I think the next session has probably already started and some of you may already be part of that. So thank you very much, Dr. Moira, and all the panelists and Nandini for an excellent session. Thank you.
Wonderful.
Thank you. Thank you, everyone.
Have a great conference.
Thank you, Mitra ma'am, Nandini ma'am. We'll join Hall A for a quiz session, and the next session in Hall B is at 5:30.
Thank you.
Thank you.